Slide, patient in sitting position, knee flex to 80 or 90 degrees. Ask the patient to asymmetrically contract the hamstring while the patient resists the backward while she flexes her knee. So contract hamstrings. So positive sign if nasa posterior subluxation and indicative of posterior lateral instability.
Koski adds.
PT instructs the patient to cross the running both leg.
Can you cross your leg?
Then PT carefully steps the involved leg, then rotates the upper torso approximately 90 degrees. Positive symptoms occur the same as bilateral shift.
Classic.
The patient lies supine with the lower limbs relaxed. The examiner grasps the big toe of the foot and lift up the foot from the examining table. The PT examines the tibial tuberosity of the patients. Then the affected knee goes into relative hyperextension. That is a positive for this test. It is a test for posterolateral rotary instability extension.
Since posteromedial and posterolateral lower side.
Sige.
Patient supine, knee flex to 80 to 90 degrees, and the hip flex to 45 degrees. The examiner medially rotates the patient's foot slightly and sits on the foot to stabilize it. Then PT pushes the tibia posteriorly, and the tibia rotates posteriorly on the medial aspect. An excessive amount relative to the normal knee, the test is positive, and it indicates posteromedial rotatory instability. A positive test indicates PCL, posterior oblique ligament, medial collateral ligament, semimembranosus tendon, posteromedial capsule, and anterior cruciate ligament. And if the medial tubercle rotates posteriorly around the posterior cruciate ligament when the tibia is in mild medial rotation, the posterior cruciate ligament is also torn, and the posteromedial movement is greater, and the tibia subluxates posteriorly.
Survival shift maneuver. This is a test for posterolateral rotary instability. The patient is standing. The tested leg is behind while the normal leg is adjusted to the wall. Then the PT grabs the inner thigh with the right hand, then the other hand is on the lower leg. The PT applies valgus stress to the patient's knee. The positive for this test is a jerk in the knee or the tibia shifts posteriorly. It indicates injury in the lateral ligament or arcuate popliteus complex.
Jerk test of Houston. Similar to pivot shift maneuver. Patient lies supine with the hip flexed to 45 degrees. With this test, the knee is first flexed to 90 degrees. The leg is then extended, maintaining medial rotation and available stress. At approximately 20 to 30 degrees of flexion, the tibia shifts forward, causing a jerk, causing a subluxation of the lateral medial plateau. With a jerk, the test is positive. A positive jerk test indicates that the same structures are injured as indicated by a positive pivot shift maneuver and assesses anterolateral rotary instability.
Yes, patient is side lying. One hand, tested leg is in the uppermost position. One hand is on the foot and medially rotates the patient's lower leg. The other hand, pushes up the biceps, biceps fat, and fibular head of the leg while extending and flexing the knee. Positive test in about 20 or 30 degrees flexion, patient feels jolt, indicative of anterolateral stability.
Lateral rotary stability test. The patient lies supine and flexes both hips and knees 90 degrees. The examiners then grasp the feet and maximally laterally rotates both tibias. The test is considered positive if the injured tibia laterally rotates excessively and there is a posterior sag of the affected tibial tubercle. For this test to be positive, both sides is there. Then it is indicative of posterolateral rotary stability.
Assuming that the patient is in supine position, the examiner holds the patient's ankle and foot so that the leg is laterally rotated and raised against the examiner's abdomen. The knee is then flexed to 30 degrees and the examiner ensures that the hamstring muscles are relaxed. The lateral rotation ensures that the subluxation of the knee is reduced at the beginning of the test. Then the examiner's other hand positioned so that the fingers lie over the patella and the thumb is hooked behind the fibular head. Then a valgus force is applied to the knee. The examiner uses the abdomen as a fulcrum while extending the patient's knee and applying a forward pressure behind the fibular head with the thumb. So if there is a clump while during the extension, the test is positive and the patient must recognize the movement as the instability that was previously experienced. The clump means that the tibia has subluxation anteriorly and indicates injury to the same structures as those indicated by positive pivot shift maneuver.
Test. The patient lies supine. Examiner stands on the side of the leg. Test left. The foot is held with one hand, which medially rotates the tibia. The knee is flexed 90 degrees. The examiner's other hand is placed over the lateral femoral line with the thumb behind the head of the fibula, pushing it forward. The examiner slowly extends the knee while pushing the head of the fibula forward, noting whether subluxation occurs, which indicates a positive test. Rotation lower test, described by Noyes et al. This test is a modification of the pivot shift maneuver. It can be used in the acutely injured knee and is not by some to be more sensitive than the other anterolateral rotary instability tests. The patient lies supine and the examiner holds the patient's ankle between the examiner's trunk and arm, with the hands around the tibia. The examiner flexes the patient's knee to 20 to 30 degrees, while maintaining the tibia in neutral rotation. The tibia is then pushed posteriorly as in a posterior lower test. This posterior movement reduces the subluxation of the tibia, indicating a positive test for anterolateral rotary instability. If the tibia is alternately pushed posteriorly and released and the femur is allowed to rotate freely, the reduction and subluxation are seen and felt as the femur rotates medially and laterally.
Anterolateral rotatory instability test. So the patient is in a side-lying position approximately 30 degrees from supination, while the bottom leg is the uninvolved leg. The knee of the uninvolved leg is flexed to add stability. Then the foot of the involved leg rests and is stabilized on the examining table with the patient's foot in medial rotation and the knee in extension and valgus.
Valgus.
So that position helps eliminate hip rotation during the test, and then the examiner applies valgus thrust to the knee while flexing the knee. So it is positive when there is a fluxation of the knee, and it is reduced between 25 degrees and 45 degrees of flexion, and indicates injury to the same structures and as indicated in the pivot shift maneuver.